Great, thanks. And I'm going to build on what Rachel talked about the importance of homes, and specifically talking about supporting parents of preschoolers and helping creating healthy home environments. So I'm from just down the road, as you mentioned. I'm just down at the University of Guelph, and I'll tell you a bit about what we're doing there. I'm also going to just start with a bit about what are Canadian preschoolers eating, what do we know about their diets currently, a little bit about why is the home environment important to intervene on, as well as talking specifically about the Guelph Family Health Study, which is an intervention we've designed to try and support healthy home environments. So things aren't looking so great when we look at what the Canadian preschoolers are eating. This is data from the Canadian Community Health Survey in 2004, and that was the most recent data, but new data is coming out from the 2015, so hopefully we'll have more up-to-date data, but it's not looking so great. About over 70% of preschoolers, so children aged 2 to 5, are not meeting the recommendation for fruit and vegetables. About a quarter of their calories are coming from the nutrient-poor, energy-dense foods. About a third of them are not eating sufficient whole grain products, and about 1 in 5 have an energy intake that seems to exceed their intake. Within the Guelph Family Health Study, we engaged families of young children, of preschool-age children in the Guelph area, and we had them collect 3-day diet records of their child's intake. And we wanted to get a sense of sort of more current data on what Canadian preschoolers are eating. And then we also were interested in thinking of a more overall measure of diet as opposed to just looking at specific foods. So one of the challenges in nutrition is if someone might be eating lots of fruits and veg, but they might just be a good eater and they might be eating lots of the nutrient-dense foods as well. And so the Healthy Eating Index is a measure of overall diet quality. And now I'm speaking to the physical activity folks in the room. And there we look at sort of adequacy components. So they get a score, a higher score if they have more of the foods we want them to eat, and those are listed there. And then there's also moderation components that are taken into account when we're thinking of the Healthy Eating Index. And we want them, if they have a higher intake there, they get lower scores in their overall intake. So how do things look? We looked at a sample of 45 preschoolers in our pilot study in the Guelph Family Health Study. And to give you context, I'm comparing it to US data from the Haines data. We don't have any Canadian data to compare it to, so we use the Haines data. This involves kids aged 2 through 17 and a substantially larger sample than what we have. But what I can show you is that total fruit, both the Americans and the Canadian kids are doing all right with regards to their total fruit. They have about, our kids had a score of 4.6 out of a total possibility of 5. Fruit and vegetables, less adequate intake. We have a score more of about 2.6, and we're doing slightly better than the Haines folks. With regards to whole grains, and this is a score out of 10, we're doing a bit better. Our kids in the Guelph Family Health Study did have fairly adequate whole grain intake. Dairy, very similar in the US and in Canada. Our protein intake out of a score of 5, so there's certainly some room for improvement there, as well as certainly with some seafood or plant protein, definitely room for improvement both in the US and the Canadian work. And then our fatty acids, so this compares sort of their intake of polyunsaturated, monounsaturated fats compared to saturated fat, and you can see our kids have some room for improvement when we're looking at the Guelph area preschoolers. Now thinking more about our moderation components, our kids did better than the Haines with regards to their score on their refined grains. Again, a higher score suggests they're having a lower intake of these refined grains. Sodium, certainly some room for improvement. They're getting a 6 out of 10. And empty calories, our kids got a better score than those in Haines. And so if you look at the total score, it looks like our kids are doing better. But before we get too cocky of our kids, remember these are the Haines is age 2 to 17, and we do know that diet quality gets worse as the kids age. And I think when we're looking at a score of 68, a solid sort of C, we know that we can do some improvement there. So now thinking about the home environment. So there's lots highlighted today about sort of the vast majority of influences across the environment, about sort of influences on kids eating. But when we're thinking of young children, a lot of their influence has to do in the home. There was a review done, a sort of knowledge mapping activity done by a group of experts within nutrition. And so they took a look at the hierarchy, or sort of looked at the research and tried to create a hierarchy of the environmental and social factors that influence child's diet and physical activity. And those experts ranked the various settings, individuals, and agencies that were sort of directly responsible for children's diet, and those were to be identified as leverage points, places we should intervene to try and change to improve children's intake. And family and home were ranked second on the list of top influences when we thought about children's diet. So some suggestion that it's important to think about home. And then when we add on the impact that the home environment or the kinds of influence home can have with regards to children's activity. So parents may provide opportunities for their children to be active. Parents are often in charge of sort of limiting screen time as well as sleep, so creating healthy sleep environment. When we add that on, it does suggest that the home environment and the family has an important influence when we're thinking about supporting healthy weights in children. And to build, to bring that point home, I borrowed this slide from my colleague Kirsten Davison at the Harvard School of Public Health, and she presented this work at the International Congress on Obesity. And here she was looking at, of the childhood obesity prevention interventions that focused on young children, sort of what ones seemed to have an impact. And that red box tells us which ones had a significant impact on children's BMI or skin fold measures with regards to obesity. And she was interested in, does setting seem to matter? These are the ones that were delivered in the home intervention. So it suggests that all the studies thus far that had been implemented within the home setting, so directly in the home setting, seem to have a significant effect on BMI and skin fold. And when we look at the same thing for some of the community interventions, again, this is the box where folks who had these studies had a significant impact on children's weight outcomes. And when we look at those in the community, it certainly suggests that the results for programs implemented in the community setting are somewhat mixed. And there's a number of potential reasons why this might be. I've done work both with community, in the community where we have families come to evening events or that type of thing, and now I have an intervention where we go directly into the home. And one of the things I always worried a bit about in the community-based work is who do we get out to our programs? And I thought about this at one night in particular where I was getting ready to go. I was leading the program. I had 2 young kids and I didn't want to go. I thought, wow, I can't believe the parents who come. And our attendance rates were often more about 60%. And when we explored, why didn't people come? It was just life. One of our kids are sick. My husband had to stay late at work. Those types of reasons why folks couldn't make it. And so one of the nice things about going into the home is I think we're able to reach, our completion rates are much higher because we're coming to where families are. So when we think about what are the key influences within the home setting, I think there's important influences with regards to the physical environment in the home, but we also know from research that the social environment seems to be also very important. And when we think about the physical environment, thinking about the availability of foods, and as many of the presentations today identified, there's a number of factors that can go into whether or not families have access fruits and veg and healthy food are available to them. Accessibility within the homes are things like, are kids able to access their own foods? Have you cut up the food so that the fruits and vegetables so they can easily grab them on their own, that type of thing. And there's also cues to eating within the home environment. I was just at the International Society for Behavioral Nutrition and Physical Activity Conference, where a team from New Zealand put cameras on children and followed them around through the day. And one of the things they looked at was where are the kids getting advertised to? And about a third of the advertising that they saw about food was in the home environment, which is sort of an interesting place to think about when we're thinking about the physical environment, maybe what kind of cues exist for supporting food. And as you can well guess, none of the advertisements were for healthy food, so thinking about that. And when we think about the social environment, as Rachel's data suggests, family meals are important. Kids who have more regular family meals seem to have healthier dietary intake. Parent modeling, so when parents do eat healthful foods, the children are more likely to as well. And there's strong literature and a growing literature thinking about food parenting. So the types of strategies we use as a way to influence the foods our children eat, not surprisingly, influences their dietary intake. So things like coercive control. Do we pressure our children to eat certain foods, and that can impact their intake? Do we provide structure? Are there specific limits about what they can eat, when they can eat it, that type of thing? And autonomy support. Are parents supportive of their children despite deciding how much they want to eat, whether they're going to eat the food, that type of thing? So a number of things when we're thinking about the home environment in children's intake, a range of influences seem to be important. So now I'm going to talk specifically about some work we've done in Guelph with the Guelph Family Health Study that's trying to understand some of these early life factors related to children's dietary intake and other health-related behaviors. But this is a family-based cohort study of families with young children, so children 18 months to 5 years. And as I mentioned, one of our goals is to understand early life risk factors for chronic disease as well as the related behaviors. But we're also a little different than sort of your standard cohort study. We also want to test and have long-term evidence of whether or not intervening and supporting families in developing healthy foods can lead to long-term sustainability of healthy behaviors. So we have really big long-term goals. We jokingly say when we recruit families that we're going to follow them forever, but what we're really hoping for is at least a 20-year follow-up. Our aspirational goal is also big. We want to become for family-based chronic disease prevention what the Framingham Heart Study has been with regards to the identification of heart disease risk factors. They've really been the leaders in helping us identify that, and we're going to try and do the same when we think about family health. So to do that, we are trying to have a really broad understanding of the factors that may influence children's health outcomes. We're looking at things like the social and family context, so level of stress within the home, parenting stress, level of family functioning, how that, as well as genetics, may influence the diet and activity and sleep behaviors of these young children. How are those behaviors influencing their body composition, as well as their blood biomarkers and their microbiome? The only way we could do that is having a very interdisciplinary team. I'm at the Applied Human Nutrition Department at the University of Guelph, and we have two nutrition departments, and so we collaborate very closely with folks in the human health and nutritional sciences. They're the folks who often do some of the mechanistic work, and we try to think about how can we take that and apply it to people's behavior. So this is a picture of David Ma. He's the director of the Guelph Family Health Study, and I'm the associate director. So this idea of bringing those two fields together. But we also have colleagues in the social sciences, biological sciences, so folks focused on the microbiome, for example. And we've also collaborated with health economists because in addition to knowing whether or not our interventions change behavior, we also want to know whether or not they're cost effective. We also have had a tremendous team of trainees, and Walu Peters is here with me as one of our trainees, and without them this stuff could not get done. So it's been a real team effort. Before we got going, we also worked to engage the knowledge users in the Guelph area. The Guelph Family Health Team provides primary care for 95% of the families in Guelph, so we wanted to make sure they were on board and make sure that our results have relevance for their own clinical work with families. Similarly, the Guelph Community Health Center provides care for the other 5% in Guelph, so we also have engaged and worked with them. We've worked with public health. They were on board early on, as well as our Ontario Early Years Center. And the goal here was, again, to make sure our results are useful for them, but they also have been really tremendous in helping us engage families, so they've helped us with recruitment throughout our research. We also talked to families, so before we went on and designed this huge study with all the families, we wanted to get a sense of what they were interested in. So we did group interviews with 31 parents, the vast majority of whom were mothers, and they asked their opinions. We wanted to know about if we thought about ways to intervene, what's the ways they wanted to see us do that. But also, as I mentioned, we have lots of things we wanted to measure, and so we needed to make sure that those were acceptable and could be done appropriately for them as well. And as I mentioned, we asked about intervention, sort of what design they would like, or where and what we should do with regards to intervention. And they told us many things, but one of the things we did is we gave a range of possibilities of ways we could intervene. So it could be a website, it could be through text message, it could be phone calls. How can we support you around creating healthy behaviors with your child? And one of the ones we provided was home visiting, and that came out as the preferable one. And they identified identified 2 ways that would be helpful. They really like the idea of one-on-one human interaction, so the chance to connect with someone. And secondly, they were cognizant of the fact that if you came into my home, you would really know what it looks like, right? So that the advice we would provide or to the support we would provide would be relevant to the setting they're in. Before we did a full study, we decided to start with a pilot study to make sure our workflow was appropriate. So we did a randomized control trial with 44 families, and this turned out to be 79 parents and 55 children. And our design was, we did a number of measures at baseline, and then they were randomized to 3 different intervention arms. There was one with 4 home visits and supportive emails, and I'll describe that in a little more detail. The second one was with 2 home visits, and the last one was control, and those folks received monthly email with general health information for their child, and then we had them back in 6 months to do the measures again. And this intervention built on some previous work that I did in Boston, which showed that using home visiting could be effective in changing children's behavior. We did a randomized controlled trial with primarily low-income families in Boston and found that families who received this intervention that promoted specific healthy routines, which were having regular family meals, creating a healthy sleep routine, so this goes to Adriana's work about thinking about sleep, limiting TV time, and then removing the television from the children's room. We were able to improve sleep, and those kids also had improved BMI outcomes compared to those in control. So some suggestion that home visiting might work. We just don't know if it works long term or works in the Canadian context. So we built on that. We had the very similar goals, but also added one around selecting water rather than a sugar-sweetened beverage or juice, and also trying to create physical activity times with your family. Our intervention, our health educators went into the homes 4 times over the 6-month intervention. They used motivational interviewing, 4 times or 2 times. Both times they used motivational interviewing, so they were actually trained by Monarch Systems, which is based here at Western University. And with the health educators, they set family goals. So we didn't tell them, and that was a bit of a surprise to them. They actually thought what we were going to do is come in and clean out their cupboards. And so we had to tell them that actually, no, we're here to work with you. You're going to work as hard as we are, and we're only going to move forward when you're ready and it's your goal. You know, you're the expert in your family, we're going to just support you through that. So they created family goals and then got follow-ups with those health educators. We also sent bi-weekly emails that were tailored to their goals. If they set a goal around sleep, then they got emails that supported that behavior. And likewise, they would get mailed incentive that supported that. So again, if they chose sleep, they got a book that, that they could use to help support their bedtime routine. So who did we get in our pilot study? One of the things we were excited about is we wanted this to be a family-based intervention. Many that say they are will take the first comer for a parent and one of the children, and we did not want that to be the case. We wanted, in families that have 2 parents, we wanted both of them to participate, and we were able to get fathers, because the vast majority of other studies had just had mothers. These guys look fairly similar to the Canadian population with regards to their weight outcomes. 84% identified as Caucasian, and we had 10% who would have been qualified as low income. The kids, our average age was about 3 years of age, and about 32% were identified as at risk or overweight based on WHO standards. So what did we hear? What did we learn? It's certainly a feasible intervention. I have not had retention rates like this in any of my other work. We had 96% of families followed up at 6 months, and everybody said they would recommend the program to a friend or a relative. We also did some qualitative interviews with families to find out, you know, what we could do better, what they liked. And this is one quote from one of our moms, one of our single moms actually, who talked about the importance of the home visits. They all really liked their health educators and quite often did not want the health educator, the home visiting to end. But they talked about how nice it was that she, you know, single mom, 2 kids, she came out my schedule. You know, she was able to sort of make it fit for us, and it was good to have someone to bounce off questions, that they could ask questions and help solidify their progress. And we have some suggestion that we may have changed dietary intake as well. Compared to control, the 4 home visit group did increase their fiber intake by 5 grams. And again, we measured this with 3-day food records before and after the intervention. We did also see an increase in fruit consumption in the 4 home visit group compared to control. We did not see any significant dietary changes from the 2 home visit compared to control. and no change in vegetable, but there was some in fruit. We also took a look at parental feeding practices. As I mentioned, this is identified as a potential influence for children's intake. And this, we found that both mothers and fathers who encouraged balanced and varied diet in their children, who provided a healthy habit, so did some strategies to try and improve access and availability to healthy foods. If they involved their children, even at this young age, in meal preparation, all of those kids had lower nutrition risk. And then interestingly, modeling healthy behaviors, among dads who modeled healthy behaviors, there was an association that those children had a lower nutrition risk compared to others. Great. So next steps, we're moving on for a full-scale trial of the home-based intervention and a much longer-term evaluation. We can now do a full-scale randomized trial with 300 families, so we're looking forward to that. And just to acknowledge our team as well as our funders. Thank you.